everyone. And today our topic is supracondylar fractures, especially atypical supracondylar fracture. And we have a esteemed faculty and speaker, Dr. Mandar Agashe, who practices at Agashe Super Speciality Hospital in Mumbai, and he's associated with 4 or 5 hospitals there in Mumbai itself. And he's a very well-known speaker and our POSI member also. And he has done his MBBS and MS from KEM Mumbai, and he has also done his fellowships from Wadia Hospital as well as US and Korea. So now I would like to invite Dr. Mandar Agashe for his talk. Welcome, Dr. Mandar.
Yeah. Thank you, Dr. Vidya Dr. Vaibhav, and the Ortho Kids Clinic. So I'll be talking to you about supracondylar humerus fractures. So I know that the basics of supracondylar humerus fractures has already been discussed. So what I'll be doing in the next 25 minutes or so is discussing some different scenarios, not the typical ones, but the atypical ones. The typical one is like this. You have a displaced supracondylar. So displaced doesn't mean atypical. Sometimes you have a displaced supracondylar which is looking very, very ghastly, and you are able to finish this close reduction and internal fixation in 15 minutes, and you are very, very happy. You feel that you have just conquered supracondylars. But sometimes what you feel is that you are not very comfortable with it. There's something weird which is happening in the supracondylar. There is something atypical. So for that, you should know what is typical supracondylar humerus fractures. So a typical supracondylar fracture is the one which passes through the olecranon fossa. So that is one thing which you should remember. It is either a short oblique or a transverse fracture. So there's not much of obliquity to it. On the other hand, there are certain atypical supracondylar fractures, which are either above the olecranon fossa, which are the high supracondylars, or the diaphysiometaphyseal fractures, or the supracondylar fractures, or they are the ones which are below the olecranon fossa, which are the low supracondylars or the transphyseals. So this is how you define it by the level of by the way of level. And second is based on pattern, whether it's a lateral oblique supracondylar or whether it's a medial oblique supracondylar. So these are based on pattern. I'll come to that later on. And what you can do is you can look at my article in IJO where I have given a few classification-based treatment algorithms. And this is how we have to do it. So we can change our pinning patterns based on the way the pattern of the supracondylar is. So a typical supracondylar, we can do just lateral pinning, but there are medial obliques, there are high supracondylars, low supracondylars, in which we have to modify the way we pin and not just go for standard lateral pinnings. What I'll be doing in the next 25 minutes is go over 7 or 8 cases which are atypical, and let's see whether we can learn something out of them. The first case, the typical one, atypical one, where we have a 1-day female where she had a difficult cesarean birth and comes with severe tenderness over the elbow and reported as elbow dislocation. Now, this is a very, very typical misdiagnosis by the radiologist. They see something weird, they say it is elbow dislocation. You get an opposite side X-ray, you can see that there is something weird going on here. And here you can see that the radiocapitular line is intact and the entire radioulnar complex is displaced medially. Now, this is a transphyseal injury of the distal humerus. It is nothing but a type 1 Salter-Harris injury of the distal humerus. So as you can see, the fracture line is below the olecranon fossa. So it's a low supracondylar or a transphyseal injury of the distal humerus. There are two etiologies. One is birth injury, and second, which is not very common in India, which is non-accidental trauma. And typically the displacement is posteromedial. Usually, if it presents early, very, very rarely, you can do a close reduction arthrogram and pinning. I have never been lucky enough to get a transphyseal so early. But typically, they present after 4 or 5 days. It just doesn't move. So I just give an above elbow slab for pain relief. Just give it a bit of valgus. Usually it heals excellently. Usually there is some cubatus varus which may remodel later on. But if required, you may do a small corrective osteotomy at that time. The next are two simple looking cases, but which are slightly atypical. You have a 6-year-old male comes with fallen outstretched hand. You have a simple looking, benign looking elbow X-ray The anterior humeral line is passing just anterior to the capitulum, and you know that this is a very benign looking grade 2A sort of supracondylar humerus fracture. And the primary orthopedic surgeon just gave an above elbow cast and was asked to follow up after 4 weeks. As against that, this is case 2B, a 6-year-old male with fallen ostrich hand, female with fallen ostrich hand, identical case. Again, the child was given an above elbow cast on day 1 and asked to follow up after 4 weeks. And what happened to these cases is that the one which was looking very, very benign, in this case, healed, but healed in cubitus varus, and that required a corrective osteotomy. As against that, the one which was displaced, looking like a type 2B with anterior humeral line passing anterior to the capitulum, it healed up completely with no cubitus varus, and this is a 6-year follow-up. The hyperextension also had remodeled, and she had a completely normal looking elbow. So why did this happen? Not all type 2s are the same. What is very, very important is you have to look at the place where there is a column comminution. So if there is a column comminution on the medial side, that means that this is likely to drift into varus, and that may require some correction. At least what you should do is never give a cast on day 1, give a slab, and then after about 4 to 5 days, once the swelling comes down, give a good correction and good cast, and then check for varus. As against that, in the other side, the column comminution is on the lateral side, and that's going to drift into a bit of valgus, which is physiological, so you can conserve them. So very, very important. These are 3 important factors, and most importantly is medial comminution, degree of extension, and the soft tissue shadow anteriorly also plays an important role. You can see that there was a huge soft tissue shadow anteriorly. That's why we could not give a thick, good snug fitting cast, and that's why the person had looseness in the cast, and that led to varus malunion. So a grade 2 supracondylar fracture can be definitely casted if and only if there is no medial comminution of the column, there is less extension, there is no rotational malalignment, and the soft tissues allow flexion more than 90 degrees. Next, we'll come to a displaced fracture. Here, the child has come after 8 days. So the atypicality here is the duration. It's an 8-day-old fracture. After about 10 to 15 days, it is said that you should not treat it acutely. You allow it to malunite and then do. Here it's an 8-day-old fracture, a high fracture, a pucker sign. Came for close reduction and internal fixation. It was just not budging. Here you have to do some joysticking. So now you have to know that these are slightly older fractures. You will not be able to get the close reduction well. In this case, what you have to know that these are irreducible supracondylars, and that irreducibility is because the brachialis has puckered in, and that in fact as the days advances that just gets plastered, and so you are not able to get a good classical close reduction because of this. So what you have to do is do something like an intrafocal wire or intrafocal joystick. You can use either a mosquito or a small thick wire which is blunted. Pass it, make a small incision in the triceps, pass it anteriorly, and rotate it at 180 degrees. You have to look at the lateral view at this time, and then yank it and lever it out. And once you have done that, you see it on the lateral view and pass the lateral entry wire. After which you can remove that intrafocal object. So this was what was done, a thick wire, which is usually blunted, reduced acceptably, and then fixed it with 2 or 3 wires as such, which heals beautifully. So this is how you can do. You can see that on the lateral view, it is perfectly aligned. On the AP view, there may be some translation, which you can then correct with the help of that wire and then fix it in the appropriate manner. So this is how you can use an intrafocal wire for atypical supracondylars. This has been well published in some of the literature. The next case is a different thing. You see that this is a 10-year-old female, a fallen outstretched hand, pain, swelling, deformity in the elbow. So the other atypicality here is that the age is a 10-year-old female, which is a peri-adolescent age. A typical supracondylar happens between 3 to 8 years. Anything above it and anything below it, your antennae have to be up, saying that this may be something which is atypical. So this looks like a very benign looking supracondylar humerus fracture. Any anticipated difficulty? Thankfully, I had anticipated it, and I had anticipated this is going to be an unstable fracture. So this was unstable in extension. This was unstable in flexion, which is very atypical for a typical type 3 supracondylar. And this was also unstable in rotation. So this is a type 4 supracondylar, where you require methods to achieve and maintain reduction. And there's a very good article by Eduardo Noyes, which we use very often, by use of an intralesional joystick method, in which the joystick is not in the fracture, but joystick is in the distal fragment. So you have to pass a wire in the distal fragment, use that to manipulate the distal fragment. So this is how it is. You use that to manipulate the distal fragment on the AP and lateral views, and then you can pass it or pass extra wires in this manner. So this was the case. You can see that it was unstable. I used this wire to manipulate and then passed it anteriorly. So this was a type 4 supracondylar. Remember, this is a very, very unstable situation. So you require these means to reduce it and fix it. And this is how you can fix it well. But can we anticipate this in this thing? So are there any telltale signs that this fracture will be multidirectionally unstable? So there's a very good article which was written by Mitchell and Smonseller, that they have given these 4 criteria, where I feel that there are these 3 or 4 articles, criteria, which are very, very important. The flexion angulation, the valgus angulation, the lateral translation, and most importantly, I feel the osseous apposition, which means that if you have a complete fracture, which is not displaced much, which has valgus angulation, translation, and osseous apposition, it means that you have to be very, very careful that it is not a very benign fracture. It is a type 4 supracondylar, and it has to be treated with very, very good amount of care. The next case is a 9-year-old female. I think someone else is.
Yeah, please mute everyone. Mute their mics. Let only Dr. Mandar speak.
Yeah, sorry. So 9-year-old female had a fallen a hard concrete from the bicycle. Comes with pain, swelling, deformity with bleeding. So this was you can see a small puncture wound on the lateral aspect, and the child comes with a dense radial nerve pulse. Now this is a supracondylar with a neural injury or neurological injury. It's a radial nerve palsy. So how do you plan for the fracture with the associated radial nerve palsy, and how do you plan for the wound? So in this case, you always attempt a close reduction. If it's a preoperative nerve injury, you always attempt a close reduction. But in case there is just a soft stop, it means that there is an interposition of the nerve inside the fracture site, in which case have a very low threshold of doing an anterior open. So remember, you open it where there is the spike. So in this case, it's an anterolateral spike. So you open it laterally in the L-shaped manner. What you can know is you can see the radial nerve was right inside the fracture site. It was entrapped. That was removed, cleared. There was some anterior comminution which I accepted. And this was 3 weeks post-op and 3 months post-op. And this, you can see that the child has gained good range of motion and the radial nerve palsy has recovered. So this was a typical supracondylar with a nerve injury, that is the radial nerve injury. The next case is the opposite. You can see that this was a fallen outstretched hand, and you can see the place where the contusion was. It was an anteromedial contusion. Here the radial artery was not palpable. Just 1 second, just 1 sec. Sorry. So this was a 6-year-old male, fallen outstretched hand. His radial artery was not palpable and had an anterior interosseous nerve palsy. Now this was a pink pulseless supracondylar with good waveform. So what do? You have various options. You are scared, but here you can see that it was not again a soft spot. So in this case also you can do an anteromedial incision. You can clear off the tissues. Here it was a vascular limb. It was not a cold white pulseless supracondylar, but it was a pink pulseless supracondylar, in which case this was swept off the fracture site. This was reduced and it went off to heal completely. So there are a few recommendations for the pink pulseless supracondylars, where you should just initially immobilize in slight flexion and do an emergent close reduction and internal fixation of the fractures. and do an open reduction for the fracture. You should not do a vascular exploration if there is a pink pulseless supracondylar. That is what you have to always remember. And remember that the pulse will not return immediately. In the excellent paper by Dr. Venkat Das and Dr. Rajshekharan from Ganga Hospital, they have shown that the pulse can return even till 6 weeks or so. So you should not be worried if you don't get a pulse immediately. So I have shown two fractures. One had a radial nerve palsy, the second had an anterior interosseous nerve palsy. So both should not be clubbed into fractures with neurovascular injury. Why is that? Basically, you have to look at where the proximal spike is. So the most important factor in supracondylar humerus fractures is the place of the proximal humeral spike. So if it's a anteromedial spike with a posterolateral displacement of the fracture, this is going to impale the median nerve and the anterior interosseous nerve and the brachial artery, and that's going to lead to a pink pulseless supracondylar with an anterior interosseous. While here it's an anterolateral spike with a posteromedial displacement, so that's going to impale the radial nerve. So look at the way the displacement is. So here it's an anteromedial spike, it's going to impale the median nerve and the brachial artery. While this is the radial nerve, this is the anterolateral spike, this is going to impale the radial nerve. So remember about these things. This is very, very important. Don't just look at the X-ray and look whether it is going to have a neurovascular injury. Look at the pattern and then anticipate what sort of neurovascular injury the child is going to have. Next case, a child had severe pain in elbow, typical elbow injury, and now has tingling over the medial two fingers. Now, this is a different type of supracondylar. You can see that this is atypical. Why? Because this is a flexion type supracondylar. And how do you diagnose it? Not just by the X-ray, but you can see the contusion here. Here, the contusion is a posteromedial contusion. So many a times, just by clinical examination, you can guess what sort of injury the child is going to have. So this was a flexion supracondylar humerus fracture with an ulnar nerve palsy. So remember, when it's a flexion supracondylar humerus fracture with an ulnar nerve palsy, you should have a very low threshold of opening up, because it's a very, very difficult fracture to reduce closed. And many a times what's going to happen, if you open, you can see that the fracture is absolutely impaling the ulnar nerve. So it's gone behind the medial intermuscular septum. It's almost impaling the ulnar nerve. And you have to clear it off. You have to bring it above the intermuscular septum and reduce it. And only then will you be able to fix it in a proper manner. So this way goes on to heal uneventfully. One of the last cases, you have a 10-year-old comes at 10 p.m. Pediatrician's nephew, displaced fracture on the elbow. So in this case, the child is not NBM. The child comes in the middle of the night. Again, a dense pucker. I just gave a slab. I thought that the child was moving the fingers well, and this was the X-ray. I said, this is a run-of-the-mill supracondylar. I think I should be able to do it well. But in this case, what I used is this very, very important article by Melman and Crawford, where they said there's no difference whether you operate in the middle of the night or in the morning. But just before the morning, there was no pulse, but the capillary refill was good. On table, there was median nerve palsy. There was this dense pucker with a dense contusion here. And this was a failed close reduction in a nursing home. So we did an open reduction in this case. The median nerve was right there and it was getting impaled, and this was then reduced. This went off to heal. But I looked at the X-ray and I felt, should I have anticipated this? So what was atypical about this fracture that led me to know that this requires surgery or open reduction? Well, the important thing is the angle of the medial spike. Remember, don't just look at the X-ray cursorily. You look at the medial spike angle. And there's a very good article by Lim et al., which shows that if the angle of the medial spike is less than 45 degrees, or the tip to skin distance, which means that if that spike is very, very close to the skin, then that has a very high chance of open reduction, complication, and increased operative time. So when you have an angle which is very, very less, it's an acute angle, it means that it is going to be problematic to do a close reduction. So have a very low threshold for thinking of doing an open reduction. So always do a detailed neurological and look closely at the X-ray and beware of the medial spike in this case. Last case, you see a routine fracture with an unexplained complications. So you have again a 7-year-old female, fallen outstretched hand. It was an absolutely uneventful surgery. Went off in 15 minutes. Absolutely, I was very happy with the reduction. I removed the wires at 3 weeks. I explained about gentle range of motion. Remember that we don't go to send to a physiotherapist. We just tell them to play actively, use a small sort of plastic cricket bat to just do some shadow batting. The child moves very easily. But unfortunately, in this case, the child had a very aggressive, very enthusiastic physiotherapist aunt who said that I will gain back the range of motion in 1 month. And what happened was child presented after 4 months with a dense myositis ossificans. So remember, passive physiotherapy should never ever be done. This can lead to a lot of issues in the future. And this, once it got completely organized, it had to be removed and excised. I got fairly good range of motion, but again, it was not full. So remember about this case that never ever do a passive physiotherapy in a case of supracondylar humerus fractures. Thank you very much. Thank you. I hope this was worthwhile. I showed a few cases which were atypical, and I hope it was useful to the fellows. Thank you very much.
Yeah, thank you, Dr. Mandar. And I think we had an interesting series and a basic, look into what do we mean by atypical supracondylar and how we can deal with it. Now, shall we start the fellows' case presentation? If
Yeah.
anyone is doing it.
Yeah.
Or if there
So,
are any questions, we can ask, and by the time the fellows.
Questions can be put in the chat box, and
All
we'll
right.
discuss all your questions one by one.
Yeah.
So we don't leave anyone out.
yeah, is my screen visible?
Yes, yes.
Yeah.
So I'll discuss about an unusual complication in a usual shaft humerus fracture. So we don't have a separate lecture on shaft humeruses. So I'm going to discuss this case. Just a second. So this is a 13-year-old girl presented with this elsewhere, managed by a general orthopedic surgeon. Sir, so how do you manage this case?
So
13-year-old girl.
So 13-year-old though comes in pediatric orthopedics, as I can see, this is almost like an adult.
Yeah.
The elbow physis is completely closed. Uh, Probably the proximal humeral physis is slightly open. Looks to be quite a thin sort of child. I'll probably give a chance of giving conservative management with a hanging arm cast or a U cast. And usually it should heal up. We have conserved even adults with shaft humerus fractures who are relatively thin. So there's no problem in trying to achieve conservative management. But there's nothing wrong in if you say that you want to do an early mobilization and do a fixation. I'll probably conserve her, sorry.
And what fixation will you choose if you want to
So,
fix it?
so I am comfortable with doing a plating. So in
Okay.
case I have to operate, then I'll do a formal plating. But in this case, as I said, I'll try to conserve her as much as possible.
Okay. Vidya sir?
Yeah, so see, I usually it's a shared decision, so I keep the options open and
Yeah,
discuss with the parents because when I say conservative, when they look at the angulation every week, they might come to me or go to another doctor.
yeah.
That will happen eventually. So I'll give them the option and I'll tell them what has advantages, what's the advantage with the immediate internal fixation, and how you need to be patient with cast management. And whatever we decide, we'll follow with that. But both should be a good option as long as we are on the same page, parents and treating
And
physician.
what will be your acceptability in a closed reduction conservative treatment?
No, it's fine. At this is not going to angulate much. If you give a hanging cast, no, you might
Okay.
get 10, 15 degrees angulation, not more than that. How is the radial nerve here? Is it okay?
Yeah, it was okay, sir.
Yeah. So then,
So,
Yeah. So as Dr. Vidyasagar said, I absolutely agree. The only thing is that what I'll try to do is try to have some form of valgus angulation. So if you have a valgus angulation, it is going to drift into neutral alignment. If you have neutral alignment, it's going to drift into varus. So probably have some amount of valgus angulation. And secondly, I'll accept translation. So that is what the parents have to accept, that the translation or slight amount of overriding should be acceptable. So I think that is something which is, as Dr. Vidyasagar said, that we should not treat the X-ray. And the parents have to be counseled that the X-ray may look a bit weird, but the child is going to have absolutely perfect result.
So
Yeah.
it was, yeah. You wanted to add something, sir?
No, go ahead.
Okay. So it was managed elsewhere by a general orthopedician, and this, okay, where did I? Just a second, sir.
Go ahead. We could see the X-rays, the next one.
Yeah.
So, Vaibhav, was it a rotational malalignment?
Yeah, exactly. I think I lost the picture of the cast. Just a second.
Yeah.
Oh my God. Sir, is my screen visible? Because
No,
No,
no.
we can't see your screen, but the
sir,
last
just a
X-ray
second.
looked as if it is 90-degree rotated.
Yeah.
Anyway, in the meanwhile, we'll take some questions. Dr. Kunal Singla has asked, Sir, how to know intraoperative stability? How do you assess the need for a third wire?
Yeah.
So that's the question.
So third wire can be either one from the medial side or one more from the lateral side. So for the medial side or a crossed wire, my indications are 5. There are only 5. One is a high supracondylar, where you will not be able to get 2 wires from the lateral side. The second wire is going to go intramedullary because that angle is going to be such that you will not be able to get a bicortical hold. Second is a low supracondylar, which is below the olecranon fossa. In this case, what's going to happen that the second wire is going to be very close to the fracture site. So in which case, if I have put two that they are going to be very close to each other, so I'll put a third one on the medial side. The third and fourth are either a medial oblique supracondylar, where just putting 2 wires on the lateral side are not going to provide stability. You need 1 wire from the medial side. If it's an intra-articular fracture in an adolescent, you require one more from the medial side. And last, a relative indication in a flexion supracondylar where you have opened medially, you put one more one on that side. For the third wire on the lateral side, I will look at, again, someone is.
Yeah, please everybody mute your mic so that only the speaker is speaking. Or if you have questions, you can ask later. Please mute yours.
So the third wire in this case, I'll put when my spacing of the 2 wires is not adequate. So my spacing of the 2 wires should be such that they intersect the fracture site in 1/3, 1/3. So that should be my spacing. So it is usually about 8 to 10 mm apart. So if my spacing is not adequate, I'll put one more wire just for stability. So that is my criteria for putting a third wire. In a type 4, I'll definitely put a third wire because it is inherently unstable. But otherwise, for all type 3s, I'll put 2 wires. I'll check if my spacing is not good, I'll put one more wire. So that is my indication.
Yeah, so the another question which we didn't get the answer was how to assess the stability intraoperatively. Once, let's say you have fixed it.
So I don't do a range because with the wires in the olecranon fossa, it's not going to range at all, or it's not going to range fully. So I basically look at if the reduction is absolutely fine, and I'm getting 2 wires which are spaced out, it is going to be stable. A type 3 supracondylar humerus fracture is going to be stable once your posterior periosteum is tightened. A type 4 supracondylar is inherently unstable because the posterior periosteum is also torn. In which case it is better to put 3 in a type 4 supracondylar. In a type 2, if my spacing is not adequate, I don't check the stability, I just put third wire.
Okay. So, Vaibhav, will you go ahead with the presentation or can we take questions?
Yeah.
Go ahead.
So basically, it was managed elsewhere, and this was the cast given. So to try to do a valgus correction, this cast was applied. Sir, what complication can you expect in this? Mandar sir?
So I think it has angulated. The fracture has started itself at the fracture site, and so that has led to a bit of angulation there itself. And I can't make out about rotation, but again, that rotations also have to be checked well.
Yeah. So she presented to us after 4 years of initial trauma with this X-ray. And this is how the fracture united. Sir, any comments?
Yeah, so this looks like a completely rotated,
Hmm.
very mal-rotated, externally rotated. The distal fragment
Yeah.
looks like as if it is fixed in external rotation. Otherwise, it's not possible to get this kind of X-ray
Yeah.
so easily. And definitely, I won't be much worried about the varus or valgus at this point, but the rotation, it makes things and life difficult for the daily function. The
Yeah.
child can't do midline function probably easily.
Absolutely.
Yeah, so she had like a 20 to 30 degree of procurvatum deformity with 60 degree of excess external rotation.
Yeah.
And hence her internal rotation was restricted. She was not able to do midline function. Sir, how will you treat this case now?
Yeah, in this case, see, this rotation is never going to remodel. If she is really concerned, and which I think she should be, that she'll not be able to button, she's not able to do a combing of hair or something of that sort, midline activities will be difficult, then definitely she needs a corrective osteotomy for her.
And which approach?
So again, you can do various approaches. You can do an anterolateral. I'll probably do a posterior approach, a formal
Okay.
posterior approach, correct it, do a proper fixation with a plate. But again, whatever you're comfortable with.
And what about the radial nerve, sir? When you derotate it again, is the radial
I
nerve?
don't
Yeah.
think there will be a big issue unless see it's going to be a 30 degrees derotation. It's not going to
Hmm.
be a very major derotation. And once you free it up on both sides, distally as well as proximally, and you have retracted it, I don't think that it will be a big issue.
Okay. So we went ahead with anterolateral approach and planned a derotation of 60 degree with wedge resection to correct procurvatum, fixing it with a 7-hole plate.
Yeah.
So radial nerve was explored initially after the approach was taken, and osteotomy site was marked after temporarily fixing the plate and checking the osteotomy site. Osteotomy was completed. A wedge was removed from the anterior aspect to correct procurvatum, and after correcting the rotational alignment, it was fixed with 7-hole 3.5 plate. This was the post-op X-ray, immediate post-op X-ray. This was the 3-month follow-up. The fracture started to heal well after 1 month and 7 months. So this was the final clinical images. Her external rotation was back to neutral. She had a good recovered the internal rotation. Yeah,
Yeah.
that was it.
Good.
Sir. Yeah.
So I think what is very, very important for all fellows to understand is that it is fine for conservative management. You should try for conservative management, and there is a lot of chance of remodeling. But remodeling is the least in rotational plane. So
Hmm.
that is something which is very, very important for everyone to understand. Be it any fracture, you should be very careful of maintaining good rotational alignment. So that is something which you should remember. Varus valgus, especially in humerus, is not very concerning to the child. It is the rotation that is concerning.
Yeah.
Now, Shashank.
So, any other cases are there?
Yeah, sir. We have 2 more cases.
Yeah, please go ahead.
I think Bipin has one case, right?
Yeah, Dr. Bipin and Dr. Shashank has one case.
Yeah.
So while Bipin presents his case, this intraoperative stability question, which was asked by Dr. Kunal,
Hmm.
the simple thing is once the fixation is done, I do a range of motion about 3-4 times, flexion and extension gently. It need not be full flexion, full extension. And then I also get a little internal and external oblique to see if the columns are matching.
Columns.
They are matching and no displacement is there, you can be assured that it is stable. And but important thing is to have that bicortical purchase. So just relying on X-rays to have that K-wires are there even without purchase would be foolish. So always have the feel as well as the look on the X-rays.
And sometimes, sir, some supracondylar fractures, we do a lateral view in external rotation. It is
Yes.
stable. But when we do internal rotation, the medial side opens up.
Yeah. So
Then
then
do you
it
add
means
a
it's a rotationally unstable fracture. Then it needs
yeah.
an additional pin. Yes.
Okay.
So I have a slightly different take to it. I usually take, I don't rotate the C-arm unless it's a type 4 or a flexion type. I take all my X-rays intraoperatively with the external rotated limb.
Okay.
With entire, once you flex it, then it gets locked, so it doesn't move. So even my post-op X-rays, there is a specific, I have a small presentation somewhere in the way I take post-op X-rays for supracondylars. Because many a times what happens is you have a perfect reduction on table, and post-operatively there is an X-ray which is done in a very oblique manner like this, and there is something which is weirdly seen. And then you have to explain to the parent, no, ये चलेगा, ऐसा ही है, कुछ दिक्कत नहीं है, whatever. So there is a way to take supracondylar humerus X-rays, the lateral view. I'll probably share it with Maulin so that you can put it across. So that is how I think you should do. I take all my intraop images with external rotation, except in type 4s where I shift the C-arm, swing the C-arm.
Okay, that's a very good point. Now, Bipin, can you start your presentation?
Yeah.
Is my screen visible, sir?
Yes,
Yes.
go ahead.
Yes, sir. Good morning, everyone. So I am presenting the case unusual supracondylar humerus fracture pattern. The 6-year-old boy fell on a point of an elbow in a trampoline. And so here are the X-rays, multifragmentary distal humerus and intra-articular involvement. So we can see one piece to multifragmentary distal humerus condyle and intra-articular involvement. So what is the mechanism? So when you fall from a height and on the elbow is in slight flexion, the semilunar notch of the ulna acts as a wedge and against the trochlear and it splits the distal humerus. So it is a rare injury, 2% of all pediatric fractures, and predominantly affects adolescents over the younger children. So there is a classification system, Muller's OTA AO classification system. 13C complete articular fracture. That C1 has an articular simple but metaphyseal also simple. C2 has articular simple but metaphyseal is multifragmentary. And C3 is articular multifragmentary. So firstly, the close treatment of fracture in young children. There is a paper in JPF 2004 that close reduction and percutaneous stabilization of pediatric T-condyle fracture of the humerus. The percutaneous threaded wire to achieve intra-articular compression and the retrograde tens to align the supracondylar part. So here we can see the threaded wire to achieve intra-articular compression and the retrograde tens. What another can be done is with hybrid percutaneous pinning and external fixation. We can pin it and do it with hybrid fixation. But with type C2 and C3, then accurate articular reduction is mandatory. And open reduction is preferred over closed reduction. And there are high rates of post-operative complications like stiffness, HO, and nerve deficits. So there is a paper in COR 1919 that intra-articular distal humerus fracture, what fractures affect the functional outcome. So articular reduction is mandatory in internal fixation. Joint stiffness and HO are main culprit. So when the fractures are open,
Bipin, go ahead and tell us what you did. So what,
yes.
other than
So there are many way approach: triceps splitting, triceps sparing, and the oligoclonal osteotomy. Each approach has its advantages and disadvantages. So coming to our case, the plan was to do close reduction in supine position, and if it failed, then we do open reduction using tricep slide approach. Sir, how will you proceed this case, sir? How will you manage this case?
So I'll, in a way, I agree that it looks to be an intra-articular and stuff. But many a times, what you see now, especially in a very young child, the X-ray which is looking very, very ghastly pre-operatively, once you give a bit of traction, the pieces do fall in place. So my final decision is going to be based on what I'll see after a traction X-ray. It's not possible to do a traction X-ray pre-operatively in a child who's howling and who's got severe pain. But on table, once I do a traction X-ray, I think I should be able to manipulate the fractures closed and put an intra-articular wire and a normal sort of wire. Here I'll put an intra-articular wire, I'll put medial wire as well as a lateral wire. So that's going to be my, so probably sort of a triangular construct in this case.
Yes, sir. So when we give traction, the pieces, yes, exactly, sir, as you said. Then we did cross pinning, and it was very stable in both AP and lateral views.
Yeah.
Thank you, sir.
So that's what. So many times you see a very ghastly looking X-ray beforehand, and you don't know the exact anatomy of the distal fragment. But once you give some traction, many a times because of the thick periosteum, they just fall back in place. You don't have to go into a very, very accurate reduction like you do in adults. Accurate intra-articular reduction as you do in adults. Many a times they just fall back in place. You can just put a wire, allow the body to heal up. It's going to heal up very, very beautifully.
So,
So,
Bipin,
good case.
arthrogram was done in this case?
No, sir.
Yeah, because sometimes I had fractures where it looked intra-articular, the extension, like a song 2 or 3. We don't know where it is extending because most of the distal humerus will be cartilaginous. But it was, in fact, extra-articular. So
Yeah.
it would be helpful in such cases to do arthrogram.
Yeah.
And in the meanwhile, we'll take another question. I think.
About the flexion supracondylar.
Yes.
So in a supracondylar humerus fracture, it is almost never that you open posteriorly. Your opening of the fracture site should be where the proximal spike is. So that is a concept which you should remember. So if it's a anterolateral spike with a posteromedial displacement extension type, you take an anterior incision with lateral extension. If it's an anteromedial spike with posterolateral displacement, you take again an anterior incision with medial extension. If it's a flexion supracondylar where the proximal spike has gone posteriorly and medially, you take a posteromedial incision like this. You should not take a posterior incision at all. I never ever take a posterior incision. It should be either anterior with medial or lateral extension or posteromedial, which is along the medial epicondyle and going right up. You will see the medial spike there. You just have to lift it up and put it back above the medial and intermuscular septum, and then it reduces. So that is how it is.
So, Tashwin, another reason is, I think, to protect the ulnar nerve because it's commonly injured almost 50% of the times, I would say. But we don't want to entrap it while reducing also. So that's the reason for medial approach, not the posterior. I understand you want to say, Tashwin, ki extension fractures, anterior approach, why not do posterior approach for flexion? But that's not true. Thank you. Shashank, come on. You can go ahead with the presentation.
Morning, sir. Is my screen visible?
Yes.
So I'm going to talk about challenges in the management of proximal humerus fracture in the brachial plexus birth injury. So our case, we had a 2.5-month-old male child who had a left-sided brachial plexus injury belonging to Narakas 2. He started crying after a regular physiotherapy session and was brought to our center. On examination, we found there was a swelling and crepitus in the left upper arm. So on radiographs, it revealed a proximal humeral metaphyseal diaphyseal junction fracture, and we decided to manage it conservatively, and we treated it velociously. So after 3 weeks of immobilization, the child was pain-free and sling was discontinued. And we asked the patient to come for regular follow-up and to assess the neurological process. At 3 months of follow-up, radiograph revealed that the fracture had united, but with a 30-degree varus angulation. So since it was acceptable, we asked for the regular follow-up. And when he came for the follow-up at the 13th month, the parents gave the history that the child had slipped from the mother's lap and he had sustained, he had redeveloped the pain. So on the radiographic examination, we found that there was a refracture at the malunion site. So on this also, we decided to treat it with conservatively, and we treated it with modified velopiosin for 3 weeks. And after 3 weeks, physical therapy was started. And in a follow-up X-rays in 1 year, it revealed that there was an increase in the varus angulation. So at 2 years follow-up, the child had almost a 45-degree of varus and 10-degree of procaveratum. And clinically, the arm was looking short. So because there was a progressive deformity in angulation, we decided to correct it, and it was corrected in both sagittal and coronal planes with a dome osteotomy, and it was fixed with 2 mm KYS in cross configuration. And limb was immobilized in a 45-degree shoulder abduction and external rotation in a shoulder spica. And 6 weeks later, follow-up radiographs were taken, and a bridging callus was seen at the osteotomy site. After that, the shoulder spike and KYs were removed, and shoulder abduction external rotation splint was prescribed for the nighttime wear. So 2 months later, the patient again presented with prominence over the lateral aspect of the proximal arm. At this time, parents didn't report any fall or malhandling. And on taking the X-rays, we found there was a refracture and the recurrence of the deformity. So we decided to fix it with a rigid fixation, and so that we can prevent the refracture and recurrence. So anterolateral approach was taken, and the bone ends were freshened, and around 2.5 mm tens was passed from lateral aspect to counteract the varus force. And the fixation was augmented with the 5-hole dynamic compression plate on the anterolateral surface of the humerus. So follow-up radiograph showed the union at the fracture site, and the arm length discrepancy of 1 centimeter was seen, and there was no deformity. 1 year after the humerus plating and nailing, he underwent an isolated latissimus dorsi tendon transfer to infraspinatus to improve his overhead abduction activities. And later the plate was removed, but the tense nail was retained to prevent the refracture. So on a recent follow-up, his arm function and everything was improved. So neuromuscular disorders usually causes changes in the bone physiology and therefore affect the bone healing. So in our case, what we saw was the process of healing was delayed and expected remodeling could not be achieved. So conservative treatment can be followed, but it is very mandatory to have a close follow-up and to assess the radiographic union, and families should be prior informed about the possibilities of need for the surgeries later. Thank you.
Yeah, thank you, Shashank. So this is also an interesting case because once I see a fracture second or third time, I would definitely send for a biopsy. Was any biopsy done and sent?
Yes, sir. Everything, even a metabolic profile was done and everything was normal.
Yeah, Shashank, can you just go back to the pre-operative X-ray?
Yes, sir.
The first pre-operative X-ray. Yeah, go ahead. Go ahead. So in this case, I would still have waited, just a 2-year-old child with any which way has a brachial plexus palsy. And as you can see, clinically, there doesn't seem to be a great amount of angulation.
Yes.
Clinically, though there is radiological angulation, but clinically the arm looks to be fairly probably parallel to the limb. The shortening may be because of the angulation as well as the slight disuse because of the brachial plexus palsy also. So I
So,
will probably
Mandar,
have
can you hear me?
conserved. Yeah, Molin. Yeah.
So the reason, of intervention was we could document radiologically progression in deformity. That is one,
Okay.
which might be due to muscle imbalance. Here, the pact and brachialis were functional, and deltoid, probably, and external rotators were not recruited adequately. The second thing is child had persistent limitation of abduction, and we thought that this varus deformity is producing mechanical blockade for improving, and that's why we decided after a lot of documentation, in every 3-monthly visit we found with an identical X-ray this is progressive, and that was the reason why the important message in this fracture is when there is underlying neuromuscular condition like spinal muscular atrophy, or so they have lesser healing potential, and immobilization should be extended till you see the obliteration of fracture lines. Now, this thing has been reported with other neuromuscular conditions. So even after removing K-wires, after seeing bridging callus, the fracture line was still visible, and the child refractured because of muscle imbalance. So after this event, we have treated couple of this metadiaphyseal humerus fracture in brachial plexus palsy patient with shoulder spica. Vulpusling doesn't control the rotations.
Yeah.
And those spicas were carried on for 5 weeks, and then the splint. So there it healed without any issue. So underlying neuromuscular condition makes this a challenging problem.
So interesting, Molin, because so just an extension of what you are saying is that we have seen a lot of clavicle fractures in brachial plexus palsy patients, and they just have non-unions, so they don't heal well. They, in fact, we have had 3 or 4 cases where they had gap non-unions after a simple childhood clavicle fractures, which probably is the commonest fracture which we see, and which heal without anything from our side. They just don't heal, and we have had a couple of cases where there was persistent gap non-unions, and that used to lead to more of sort of internal rotation, sort of posturing of the shoulder, which needed interventions later on. So I think it's a very interesting point that neuromuscular conditions hamper bone healing in kids.
So
I think
we
that's
have
a
published this
very
in JBJ's case connector.
Yeah.
And in discussion, we have provided a lot of literature about bone healing issues in neuromuscular condition. It's worth reading.
Yeah, great.
Are your patients with clavicle fracture underwent nerve surgery, or
Yes.
even
So
without
in
nerve
fact,
surgery?
we had thought that it was because of nerve surgeries. And we had thought that earlier we used to do clavicular osteotomies for the nerve explorations. And there was one child who had a clavicular osteotomy at that time, which had healed up. And then later on, she developed a clavicle fracture, and that went to non-union. But it was not the case for all of our cases. There were some who had exploration without clavicle osteotomy. There were some who had
Those
no
were the birth
intervention.
trauma which failed to heal. That's what you try to say. Yeah?
Probably, yeah. So I don't know. So I don't know why it happens. Probably it is because of less vascularity. I'll just probably send across a few of our cases to you, whether you have some other input also.
Yeah. Fine.
Colin sir, I
So when
wanted to
now
ask.
we treat them with shoulder spica, even young child,
Yeah,
and
agreed.
keep the spica on for little
For a
longer
long
time
time.
than you
Yeah.
think, because they might go for non-union.
Yeah.
So, do we have any more questions from the audience?
Sir, I wanted to ask Colin sir one question.
Yeah, please go ahead.
Sir, when we treat the fractures by shoulder spike application in brachial plexus, Do we keep them in external rotation or in internal rotation?
External rotation and abduction is
Yeah.
advised for two things. One, the deltoid and supraspinatus will pull the proximal fragment in abduction external rotation. And secondly, you want to counteract the brachialis power, brachialis angulation force. So should be applied in 45-degree abduction and external rotation. Kunal, is that?
Yes, sir. Thank you, sir.
Can you get it?
Yes, sir. Yes.
So anything else? So Mandar, I would like to ask something.
Yeah.
The type 1B fractures where there is benign looking fractures with middle
Yeah.
compression which tend to go into varus. Do you always fix them, or what cast you are talking about? Do you use that cast?
So I feel the problem here is if you give a cast on day one, many a times it slips, and that slippage is because the child is going to keep here like this, it's going to slip in varus. So my take in all fractures is I almost never give a cast on day one for any fracture. So I give a slab first, let the swelling come down, and after about 4 to 5 days, when the child is very comfortable, and you give a nice snug fitting cast, you can probably give a slight valgus sort of mold so that it will stay in. Whatever that varus angulation is going to take place, it's going to take place between say 5 to 14 days, where the plaster has slipped, and that is going to malunite into varus. So I think that is what my take home is. I don't fix a type 1B, but I'll definitely give a cast after a few days, which is a very snug fitting cast. So as you can see on that X-ray, there's a lot of soft tissue shadow anteriorly. So that soft tissue shadow led it to have a very loose sort of cast after a few days, and that led to the varus angulation.
Yeah. So another thing is because see, biomechanically, if you want to control varus and valgus, it is best done in elbow extension.
Yes.
So would you give a cast in elbow extension or flexion?
So I had attempted elbow extension in a few cases. I and the child was not very comfortable because it has to be hanging always. It can't be kept close to the body. That is one thing. Secondly, if at all you have to give a cast in elbow extension, a very, very important thing to do is you have to always include the thumb in the cast. Otherwise, what happens is that because of gravity, it slips down and there's a lot of sores around the base of the thumb. And that once you include the thumb, it doesn't slip down and the plaster stays well in place. So I think if at all you want to give a cast in extension, see to it that you have included the thumb like in a thumb spica.
Yes.
So-
Most important thing is to recognize them.
Yeah.
Vidya.
Yes, sir.
So my indication of extension cast is, some of these patients from remote centers, they present to us after 10 days or a couple of weeks, where they have some sagittal malpositioning that we know that it will remodel. Now, if you don't want to do this osteoclysis and intrafocal pinning, then I try to put it in extension, align the varus valgus, keep it neutral, a bit of valgus, and keep this sagittal deformity like that and apply plaster for a couple of weeks or 3 weeks in extension. And as there is no coronal deformity, sagittal deformity is anyway going to remodel. So that is the indication where to avoid, surgical intervention, child's understanding family is not well, that the myositis or limitation of motion or is because of their late presentation and not because of our treatment. There we will do just casting and extension. Now this was done by Dr. Bill Cole in sick kids. He is kind of similar person as K. Wilkins for Canada, So he had treated and he had shown results of some late presenting supracondylars, where you just control your coronal, as you rightly said, that your coronal alignment can be treated well in extension than flexion. And Mandar has given a nice point that you include the thumb so that it doesn't slip off. That is very right. So all cases have been presented, all three?
Yep.
Yeah, all are done.
Hello?
Yes, all three are done.
All cases are done, sir.
Yeah. So all cases had some different message. This external rotation after humeral, then other is an internal rotation deformity.
Yeah. So that's what I said to all the fellows. It is okay to do conservative management, but you really have to look at the rotational malalignment. Everything else will remodel well to some extent, but the rotational malalignment is very, very unforgiving. So that has to be really checked for in case when you are giving a conservative management.
What I see, Mandar, is we teach the complex operations nicely to the fellows, but we
Yeah,
don't teach how to apply simple plasters.
absolutely.
Many of us fellows, they don't know how to apply hanging cast.
Yeah.
Many of them, they don't know how to do a Volpius sling. The other day, I saw 1-year-old with shaft humerus fracture treated with TENS, and then TENS entry got infected and so on. So maybe in POSI, like this time we did this cast. This was a nice workshop, but that's the need of time that we should also teach how to well treat conservatively. Anyways. So
All right.
thanks, Mandar and Vidya, for your time.
Thank you, Mandar. Thank you, sir.
So I could not join in time, but
No problem.
thank you very much.
So just as a last point, I've just been appointed as editor of the IJPO. So in case you have any good articles or case reports or original series, please feel free to send it to the IJPO. I'll send it across about where and how to apply. And it's our official journal of the POSI. So we should encourage our fellows and our consultants to send it to IJPO.
Absolutely.
So please encourage.
So we have written up this external rotation deformity after humeral shaft fracture.
Yeah.
And I asked Kunal to send me. I'll review and we will submit it.
Perfect. Thank you so much.
Okay. Sure. Take care.
All right. Bye bye.
Thank you, Mandar. Thank you,
Thank you.
Mullins.
Bye.
Thank you.
Bye.
Take care.